Module 3, Objective 16, describe the range of motions that are associated with synovial joints that fall under angular, rotational, and special movements. In terms of angular movements, we have a wide range of motions that our joints allow. And while definitions are located here for flexion, extension, and hyperextension, I'm going to jump to the next slide where it's just a little easier to visualize. So flexion is defined as the reduction in the angle between two body parts. And again, if we go back one slide, we can see that decrease the angle between two articulating bones. So flexion allows for a decrease in the angle between two body parts. And the way this image is arranged, these little red spheres or dots represent joints that allow for these particular movements. So flexion and extension can all occur at the elbow, they can occur at the hip, they can occur in the neck, and at the wrist. So we can flex, that's going to decrease the angle between the two body parts. Extension is just the opposite. It's an increase in the angle between two body parts. In addition to that, we have hyperextension, and hyperextension isn't as common amongst these joints. In fact, if you can take the elbow and you flex it, so you bend the elbow up, we flex. When we extend back to anatomical position, our arm should be straight, and the elbow does not allow for a hyperextension. You cannot take the elbow back. The anatomy of the joint just doesn't allow for that motion. So the elbow cannot hyperextend, but the hip can. So right here at the hip, you can flex, you can extend it back to anatomical position, and then a hyperextension. And as we see in the definition before, hyperextension is extension past anatomical position. Extension past anatomical position. So at the hip, we can hyperextend. We can also hyperextend at the neck. To flex, we can put our chin down towards our chest. We can extend it back into anatomical position with head facing forward. And then we can hyperextend simply by taking it back beyond anatomical position. The wrist is the same way. We can flex the wrist, we can extend it back, and then we can hyperextend it. Abduction and adduction. Abduction, ABD, is the movement away from the longitudinal axis, while adduction, ADD, is movement toward. We can ab and adduct at the shoulder, the hip, the wrist, or right here between the metacarpals and the phalanges. So to abduct, you're taking it away from the longitudinal axis of the body. To take away, to abduct, when a child is abducted, they're taken away. So to abduct, you're taking away. To adduct, you're adding it back. ADD, adding it back. Boy, that was a bit awkward. But you're adding it back towards the longitudinal axis. So again, we can practice all of these motions. And I would highly recommend you doing that, getting up and actually doing the motions. It's great for the cardiovascular system. It gets your circulation pumping a little bit, pumps some blood into that brain so you can convert some of these short-term memories into long. But it also helps reinforce just these actions, and that's the best way to learn them. So please do so. Rotations, we have two types. We have medial rotation and lateral rotation. Again, medial rotation is rotation towards that midline or the longitudinal axis of the body, while lateral rotation is rotation away. We can medially and laterally rotate at the shoulder, and pay attention to the hands because the hands make the difference. They differentiate between rotation and just simple ab or adduction. So a lateral rotation is one in which you move away from the longitudinal axis, But you start out with palms facing backwards or posteriorly, and at the end, you're going to rotate at the shoulders to where palms are facing anteriorly. So that is lateral rotation. Medial rotation is just the opposite. You're going to rotate at the shoulder so that palms are facing posteriorly again. The head can also rotate, but it rotates left versus right. And all you have to remember is that left and right is always with respect to the patient. So do not impose your left and right onto a patient that you're facing, because it doesn't work that way. Pronation is a rotation of the forearm so that the radius rolls across the ulna, and it results in the palm facing posteriorly, while supination, the palm is facing anteriorly and the forearm is supinated back to anatomical position. Let's take a look at that. We can pronate and supinate at the elbow as well as the wrist. And again, it's just a little bit of a trick where the palm is going to either face posteriorly or anteriorly. So the shoulder does not move. There's a big tendency to medially and laterally rotate at the shoulder, but the shoulder does not move. Sometimes it helps if you cup your elbow and just allow for movement there. But what we're looking at is the basically the radius and ulna within the forearm, and you can see that they're literally sort of changing position during pronation and supination. As a student, I always remembered supination always ended with palms facing sort of anteriorly. If you cup your palm, it's almost like having a bowl of soup. And pronation, your palms are facing posteriorly or down. It's sort of awkward to describe that. It's much easier to demonstrate it in class, but that is pronation and supination. There are some special movements that we're going to go through. So we can invert or evert. Inversion is a twisting of the sole of the foot medially. So we can see an inversion. Let me change colors so you can differentiate right here. And then eversion is a twisting of the sole of the foot laterally. So this is purely at the ankle. The ankle can also dorsiflect and plantar flect. Dorsiflexion is a flexion at the ankle, lifting of the toes, while plantar flexion is an extension at the ankle or pointing of the toes down. So dorsi versus plantar flexion. Opposition is movement of the thumbs towards the palm or the other fingers. The opposable thumb is what differentiates primates from lower animals, mammals specifically. We have the ability to pull or oppose our thumb over to our little pinky, and that allowed us to grasp, which led to all kinds of advances when we could use tools and whatnot. Reposition is the opposite of opposition. You just sort of reposition your thumb back to anatomical position. At the temporal mandibular joint, right here, we can protract and retract. Protract is jutting the lower jaw out or anteriorly, while retraction is the opposite. You're pulling it back posteriorly. Depression and elevation, also at the temporal mandibular joint or the jaw joint. To depress, it is going to move a structure inferiorly down. That causes an opening of the mouth. Please do not confuse depression with opening mouth. The actual range of motion is depression at the temporal mandibular joint. It leads to an opening of the mouth. Elevation is just the opposite. You're going to move a structure superiorly, such as a process that leads to closing of the mouth. We can also laterally flect the vertebral column from side to side, which leads to this imagery right here. And that ends this module.